Welcome to Healthcare du Jour, where we dish up and digest the latest in healthcare. For the next 30 minutes, sit back as we bring you insight, commentary, and discussion on trending topics to the table, all expertly served up by our host and his guests. Healthcare du Jour is brought to you by High Tech Answers and Healthcare Now Radio, part of the Answers Media Network, and is sponsored by the law offices of Myrick O'Connell. Now here is your host, Matt Fisher.
Welcome back, and thank you for joining as we dive into the hottest topics in healthcare. I'm your host, Matt Fisher. On the menu today is Christine Parent, Associate Vice President at Meditech. Welcome, Christine.
Thank you for having me.
Yeah, no, it's a pleasure to have you on. But before we kind of really dive into our conversation today, I always like my guests to be able to provide a little introduction in terms of who they are and what they do.
Perfect. So my name is Christine Parent, and as you mentioned, I'm AVP over Marketing for Meditech. And I actually began my career here at Meditech about 24 years ago, and I was on the operations side installing many healthcare systems throughout the U.S., Canada, and I had the opportunity to actually install some healthcare systems out in the U.K., which was a very interesting experience for me. I've actually been in almost every division within Meditech, starting in implementation, but I also worked with the service side and also worked in development for a period of time. So it's really given me that well-rounded view of what's going on within the vendor world and spectrum and kind of each area working with the customers directly and then obviously internally with our teams as well. Most recently, I was over our operations for our home care and hospice division, so a different industry altogether within healthcare, and that was out of Atlanta. So I did about 3 years ago, transitioned over to marketing. And we have a new sales and marketing senior executive vice president. And what she really wanted to do was start to transition the company to be more away from the inpatient and acute space, but really put that messaging out there that we're much more than that inpatient environment. We have these solutions in the different areas with home care, hospice, specifically a very strong physician and ambulatory solutions, behavioral health, et cetera. So that is my marching orders right now, is to really speak to the industry about the breadth and of our solutions and to give you a understanding of who Meditech is. We have over 20% of the U.S. market share in the EMR market in the U.S. and then 40% in Canada as well, as we're across 22 different countries globally. So, you know, I'm proud to be here today to talk about some interesting topics that are facing healthcare today.
Yeah, and actually, it's kind of nice to hear the description of your experience, which, as you said, has covered so many different areas and also recently covered different pieces of the healthcare industry, of not just, the hospital or physician aspect that people might think of. So kind of with your breadth of experience, how have you seen kind of the evolution of the EMR over that 20 plus year period that you described? 'Cause, I suspect most people hadn't really even thought of an EMR until less than 10 years ago with the Meaningful Use program.
Sure. I'll say that you're 100% correct. And I think that we're seeing a lot with EMR, with just where the patients are arriving for services, is being more shifted to the outpatient environment. That we see that heavily. We actually, a few years back, during the Meaningful Use portion, we actually rewrote our physician products in our tools to the newest user interface, and almost from the ground up to really redesign those process flows. So the industry has very much changed. The continuum of care and the need to do tighter integration, not only within a health system, but also across different care areas. So whether, I mentioned hospice and home care, how do you integrate so that that the person that you're caring for went into the emergency room and had a emergency procedure? Is that going to throw off your schedule, or how do you go ahead and manage when the patient arrives back at home? Are there any additional conditions or care treatments that they'll need based on their last day? So really tightening up that integration, that's a huge thing. I mentioned home care and hospice, but I also did some work with skilled nursing and some long-term acute care facilities as well. So just the need to branch into those areas and making sure that all of the information and data is flowing based on where the patient is presenting. And not just that, I think that, and I know we're going to get into this a little bit, but the complexity of how much data is out there now, and making sure that when the patient does enter wherever the spectrum of the healthcare system is working with the physicians and the clinicians to make sure that not only is the data there when they need it, but the viewing of that data makes sense. I think as the industry has advanced with interoperability, we used to say that the data's not there. I think that we've changed that discussion, and we're saying the data's there, but in some cases it's not readable. It's too much. It's not, I don't know where to find it. So I do think that that has also kind of changed and progressed as the EMR market and as the interoperability and as these various care areas have really started to implement the EMRs within those environments as well.
There's a lot to unpack in that kind of statement that you just gave. And I think one of the things I want to pick up on first is you're talking about the different parts of the industry, like hospice or home health or skilled nursing. Obviously those areas of the industry were kind of left out or left behind in terms of incentive money to adopt. So do you have a sense of where those segments of the industry stand in terms of implementing EMRs?
Perfect question, and you're 100% correct. The example I'll give you is we recently had a forum last fall, actually, and we're getting ready to do our forum in a couple of months here with CIOs. And the question that was asked is around the incentives, correct? Because, I think that we saw that meaningful use really drove the EMR adoption. I read recently where ONC was stating now that about 90% plus of physicians are now working off of an EMR, which obviously that's attributed to the meaningful use. But what about those care areas such as nursing homes that have not had the incentive to actually adopt an EMR? But again, as we go to value-based reimbursement model, they're going to have to be part of the spectrum in the care for the community around the population health and these value-based payment models. So the question that was posed at the forum was a survey and asked people at the acute level, so the inpatient hospital level, how many of them have gone to their neighboring nursing homes and have extended or offered to either pay or implement an EMR system so that all information is available and working very closely, almost in partnership. And you would be surprised at the number of hands that have been raised. So you're 100% correct that those are, quote unquote, some industries that have been left behind per se. Nursing homes, I think, being probably the one that seems to not have that structure and that push to get that data online. But what you're seeing as a result of some of these value-based initiatives is the hospitals or the healthcare systems really reaching out that arm. I mentioned obviously working with home care, and the reimbursement models for some of the home care services have not caught up to where they need to be, really to do that full population health within that community. And so you have seen that there's actual, on the inpatient and the organizational level, them extending their technologies and actually extending different services and initiatives that maybe are not reimbursable, but they understand at a very wide glance that this is needed to actually drive down those costs overall, maybe not short term, but more long term, as well as really start to build out that better wellness community and that better interaction with these different areas.
Yeah, no, it's very interesting in terms of what you're talking about with the shift to value-based care quality of, I definitely agree with you that you can't do that without alignment across all segments. And hearing that, the results of that, in-person survey, I think you were talking about, where so many sounded like a decent number of systems were providing assistance. Coming from the regulatory perspective, it's interesting because it's oftentimes to have that type of financial assistance is very problematic under the fraud and abuse regulations. But if you're in one of the kind of demonstration value-based care programs or the innovation models through CMS, you get waivers.
Right.
And it's I think it's kind of, as you're saying, you have to recognize that the system as a whole is fundamentally changing, and you're trying to create aligned incentives as opposed to each provider or piece of the industry trying to do as many services as it can, because that was how it got paid. But now you're working off of a single pot of money. So why shouldn't we be trying to help all different care providers within the industry come together and be able to have data going back and forth and be doing what's best for the patients.
Exactly, and we see it's almost changed even some roles and process flows within the organizations. You've probably heard the concept of nurse navigators, who now really sit at that top and help really make sure that the patient is actually getting the right level of care within their whole health system and monitoring that patient even post-discharge. So it really, you see, value-based care. It's probably not as quick as people thought it would be. There's still some fee-for-service out there in the industry. We see our customers doing it today in time. But what I would say to you is everyone knows that this is where the shift is. How quickly we all get there 100% is one thing, but we have to make sure that, from a vendor perspective, we know where the industry is going. We've kind of talked to our customers, and they agree. And so we have to make sure that we have the tools, and part of that is integration. Part of that is, the EMR views. If you're in a home care environment versus a ED environment versus a physician office, your views, the information you need, how much information you need, what are you collecting for data, all changes. So from a vendor perspective, really going into these various areas, you better know these industries because they are very different. And talking to an ambulatory customer or going to a physician office is very different than talking to a hospitalist that works within the acute environment. So that has been some of the complexity as well that I think that from an EHR IT perspective, we've had to tackle. And like you said, it's really needed to have that whole alignment so that you're doing the right thing for the patient and you're providing the best quality and you're trying to essentially also reduce costs at the same time.
To your point that each of those providers is looking for and needs different types of information, to now ask what's probably going to be an extremely difficult and nuanced question. What are some of the challenges in terms of designing an EMR around both the interface, because as you were saying, each different provider wants to see different information, but then also standardizing probably the data in the background so that as it's put into the system in different ways, it still translates into the same meaning.
Sure. So you're kind of, that's a really good question, by the way. So it's two pronged. So I think that first off, from a design standpoint, and I can speak to this from a recent place, because like I mentioned, Meditech, we just released our Expanse platform, which is the first post-meaningful use platform. But why I say that is more for the fact that we were able to, we have some of these legacy other EMR vendors out there that might have constructed their physician products, 20 years ago. And not only were the complexities of medicine and some of what needs to be done at a specialty level, but even how you process and your workflow was very different. So when we started this undertaking, probably about 7 to 8 years ago, we actually really tried to bring in those physicians as part of the design. So we went to an agile development process. We brought the physicians in, and it was really great to have them work alongside with our designers, and also our developers, and it was interesting for them. I had one family doctor say, if I'm going to stare at a screen all day, it better be a really pretty screen and better have what I need. So part of that is, trying to flatten out the experience. We went to more of a modern user interface, so it's much more like, I don't know if you have any parents that, have kind of not gone to technology, but all of a sudden they find an Apple phone, and the next thing you know, you're getting text messages and they're online, like my parents have, really embraced that new user interface technology. We've really designed that for the EHR now. So I think that's huge. But what I would say to you is on the governance perspective, there is some need to have some standard content out there. So we have worked with a couple other vendors on evidence-based content. And part of our implementation process for the physician products is a multidisciplinary, it's called CLPP, and it's a leadership preparedness program, and part of that is around governance, how to go through the various multidisciplinary committees such as nursing and pharmacy, and really collectively work together as a whole to make sure that you're doing the right thing from a process standpoint. But knowing that as you mentioned, different specialties need different information, there are some ability, and we've built this in ourselves, and not only you need different content, but the ability to do some personalization. And so, how do you create, like you were talking about, the data points and the data to make sure that it's standard so that when you start to do analytics, apples to apples makes sense, and you can really start to report off of information, see how you're trending in different areas, and also compare physician to physician in certain areas, let's be honest. But have the ability to be able to personalize that experience based on either where you're working. Are you an L&D physician? Are you a hospitalist? Are you an ED physician? And maybe for certain physicians, they like to see information in particular areas based on how they're used to working. So there is the ability to not necessarily completely customize across the board. We don't like that word, customize by physician, but there is the ability to what we consider personalize the information so that the data being displayed, how they progress throughout their day, really meets the individual physician needs or the specialty needs.
For those of you just joining, I'm talking with Christine Parent from Meditech. We've been talking about design, implementation, and evolution of electronic medical records. And Christine, picking up on what you're just talking about, and I agree, I've heard that customization is the word that you don't want to hear when it comes to implementation of an EMR, but the personalization and, as you said, kind of the ability to get into the data, it feels like as you're describing it, and one would hope this would actually be the case, is that you're moving away from the electronic medical record being just an electronic version of a paper record to a more comprehensive, I guess, recording and analytics system that can provide assistance in being able to both record and crunch through all the data, so that way it's not necessarily just a passive tool, but something that's active within the process and feeding additional information to users and others that are connecting to it.
Absolutely, and that is, if you don't have an EHR vendor that's doing that today in time, they're not going to be in business very long. That's exactly what I was describing. We have an active, on the inpatient side, surveillance system, so that as lab results are coming in, it's actually sending it and broadcasting it everywhere. You have some sort of abnormal, lab results, someone is going to be notified. You have someone that looks like they're turning septic. There's alerts that can be sent to multiple individuals with protocols that are already, or care plans that are already kind of predefined by the organization on what those best practices are. So we also on the outpatient side have registries, active registries. So as people are trending, maybe they went home with a telehealth, whether it's glucose monitor or other patient generated health data monitors. Information will come in real time, and again, alerts may notify someone in home care, may notify a nurse navigator, may send something directly to the nurse in the provider practice. So absolutely using that information, crunching that information. There's a lot of use, like I said, on surveillance right now to reduce readmissions, et cetera. So that is something that EHRs have to do. The thing I will say, they have to do it smartly. There needs to, by institution, for them to work with the vendor to try to figure out from their institution what those protocols are going to be, what those algorithms are going to be. You don't want these physicians and clinicians to receive this alert fatigue. You don't need every single piece of data pushed to them when there is an abnormal. So really working to define and refine that is huge.
Yes, no, I agree, because there's so much data flowing through that if you're just pinging somebody with every bit that comes through, it's going to get ignored, and then you've just created probably a worse problem than you had before.
And I will say it's been an evolution even on the EHR side and working with our customers. You know, we have some toolkits that are best practices that we work with our customers during their installation, even beyond to install. And we have gone back and refined those toolkits, you know, as more data is known and as more evidence gets posted. And like I said, you know, I think it's an evolution. We continue to get smarter as an industry, and we listen to our customers. We work side by side with them. We're part of various organizations, and we have good partners on the third-party vendor side to really help advance us in some of these areas. So yeah, like I said, if you're not doing that now and you're not taking that data and making it active and putting it in their workflow, so it's not a different area that they need to constantly go in and view, it has to be part of their workflow. How to do that, how to do it at the bedside, how to do it when they're interacting or calling up a patient chart, that is critical, and that's the only way that we're going to successfully be able to move our health systems to be successful as we move to value-based.
Yes, no, the evolution that you're describing is really the fact. Not standing still really applies to everybody in the industry, whether you're talking vendor, provider, or anybody else. It's, you know, if you think you can stay with how things have been in the past, you're going to get left behind pretty quickly. But in kind of thinking about that evolution, you know, that can generate potentially negative headlines or negative coverage for, you know, I think probably fairly to everybody in this industry of, you know, not doing everything that's possible to help with that, or, you know, or just maybe not moving as quickly as one would anticipate. So kind of building off of that idea, you know, when there is criticism directed towards the EMR industry, and obviously not just, you know, thinking about it as a whole and not trying to pick on any one vendor, but where is that criticism misdirected? So, you know, where is it unfairly being placed? And then, you know, what area would you suggest does need additional improvement?
So, and I recognize, you know, that I go to different conferences. We kind of hear collectively the voices from not only our customers, but just across the healthcare community as a whole. I would say that the two areas that we tend to hear the most out of is interoperability. You know, I think that we've made some huge strides in interoperability, and the mandates, obviously, with the meaningful use with APIs is obviously a positive thing. I think we would have gotten there anyways. EHR vendors have been working with third-party vendors with APIs already. And, you know, I will say that our work, you know, in some cases with Commonwealth Alliance, we actually just went live with the FHIR standards using their services with one of our customers, and we're rolling that out right now. The recent announcement with Commonwealth and Care Quality is a huge thing, I think, for the industry. And then on its heels, the apps and the ability to really create that innovation that I think is what the health systems have been thirsting for. And I do think it's going to, from an EHR perspective, really change our landscape a bit on who we're partnering with, what type of innovation that we could introduce to the users that need it right now, that maybe from an EHR perspective, we're focused on more the framework. They're going to be focused on the individual areas, adding some of this new innovation and technology that they can, whether it's the patient, whether it's the provider, whether it's the nurse, take advantage of. The other area that I would say that we hear a lot about, and you probably have read, you know, ad nauseum, like all the various news articles about physician burnout, is just the fatigue that physicians feel with the EHR system. You know, I think when meaningful use began, they bought into, you know, the whole premise of meaningful use was to provide better quality care at a lower cost, and they were going to use technology as the catalyst to get those outcomes. And so what I would say is a lot of systems at that time, now this is a number of years ago, really forced in a very short period of time physicians onto an EHR system. They didn't have the luxury of going through a full implementation process, making sure that they had all their design needs met. And in many cases, you had physicians that were still trying to fight going onto a system a little bit. You know, that was not what they went to medical school for. So I would say a lot of it was meaningful use regulations. A lot of it was the EHR industry being on the I guess, earlier stages of the physician's life cycle of the products, and really understanding the tools needed, understanding the workflow needed, understanding the additional documentation that was going to be required for meaningful use. I think that, they mentioned that with the physician burnouts, I think almost 60% of physicians that claim that they have some sort of burnout are using an EHR system, which I think is something that we as an industry have to recognize and take a look at. There are things and methods that I believe that at least for my organization, that we have learned from. I mentioned that we rewrote our physician products. We just actually went to market about 2 or 3 years ago to complete all of them because it's a new world for them. It's a new paradigm. We've learned a lot. Meaningful use, this is post-meaningful use now. It's not, this isn't a system from the 1990s. Hospitals look very different. The way that the physicians need to interact is very different. The devices that they can use is very different. The navigation with the user interfaces that they can use is very different. So those are the two areas, interoperability and usability, are the areas that we hear the most criticism out of. And what I would say to you is that we own some of it. And I think we have to acknowledge it to do better and to do better for our customers in the healthcare environment. And it's what your EMR vendors are doing to help address it and kind of move that cart forward is really the most important thing. And if I can just add one more thing, I will say, I think a lot of the solutions that we're talking about is instead of putting us as the adversaries sometimes, the EHR vendors, really including us more on a collaborative and partnership basis. And I say that not just with health systems or, physicians pointing to, whatever their EHR vendor is, but also from a payer perspective, from a government perspective, from a vendor-to-vendor perspective. If we can do more of those, care equality to the Commonwealth type of getting together and collaborating, that is how we're going to be more successful as an industry and really move this industry forward to where it needs to be.
I very much like that idea of collaboration, and it really kind of ties together everything that we're talking about, which is the industry is moving to a place of alignment and everyone working together. And as you're suggesting, very rightly so, in my opinion, that alignment needs to go across everybody. And I think that's a great takeaway message because, believe it or not, we are already out of time. So I want to thank my guest, Christine Parent, for a great conversation today.
Thank you very much for having me.
And thank you to everyone listening. Keep the dialogue going and connect with me at #HCDEJURE. I'm Matt Fisher. Until next time.